My name is Constance Harrell Shreckengost, and I'm a third-year general surgery resident and current global surgery research fellow from Emory University. Today, I'll be presenting my analysis of work performed by colleagues at Lifebox, a UK-based nonprofit that seeks to make surgery and anesthesia safer for all. This presentation, entitled Clean and Confident, discusses the impact of sterile instrument processing workshops on knowledge and confidence in 5 low and middle income countries. Surgical instrument sterility is fundamental to ensuring the safety of any surgery, so much so that it is often taken for granted. However, lapses in sterile instrument processing can have major repercussions. While such lapses can occur anywhere, facilities in low and middle income countries are more likely than those in high income countries to have sterile processing departments that fail to meet international standards. With this in mind, Lifebox partnered with the Sterile Processing Education Charitable Trust to mount several sterile processing workshops in both Ethiopia and select countries in Central America. A training of trainers model was used in which sterile processing nurses and technicians were recruited from hospitals across Ethiopia, El Salvador, Guatemala, Honduras, and Nicaragua. As seen in Table 1, 4 TOT workshops were mounted for participants in Ethiopia, while 1 such workshop was mounted in El Salvador for all Central American participants. Trained trainers from the Central American workshop subsequently led 9 non-TOT workshops in their home countries, shown in Table 2. All workshops covered the fundamentals of the sterile processing cycle, including cleaning, packaging, disinfection, sterilization, and transportation. Participants completed multiple choice pre- and post-tests, demonstrated skill competencies, and shared feedback by survey. In Ethiopia, in-hospital observations of 4 sterile processing metrics were also obtained pre- and post-workshop. These observations were performed as part of a larger quality improvement project called CleanCut. Now we'll discuss the results of the TOT, or Training of Trainers workshops. 60 Ethiopians and 13 Central Americans participated. As seen in Figure 1, participants in both locations rated pre- and post-workshop sterile processing knowledge on a scale from 1 to 10. And in both locations, participants reported significantly increased knowledge post-workshop. As seen in Figure 2, participants in both locations showed improvements between pre- and post-workshop tests of sterile processing theory. While Central Americans rated workshop utility more highly than Ethiopians, participants in both locations found the workshop helpful, with average ratings above 9 out of 10 in both locations. Participants also rated their confidence in teaching and enacting change as not at all, somewhat, or very. The majority of participants in both locations were very confident in their ability to teach the sterile processing material. However, fewer participants were very confident in their ability to enact change. Free text responses as to why they lacked confidence indicated lack of administrative support and lack of resources as major factors. In Ethiopia, 4 sterile processing metrics were observed in 7 hospitals before and after the workshops. After the workshops, instrument trays were more likely to have a sterility indicator. Trays were also more likely to be replaced if found to be wet. From the 4 indicators collected, 2 overall compliance measures were calculated. Both of these measures, sterility confirmation and instrument compliance, improved post-workshop. In Central America, trained sterile processing nurses and technicians used the knowledge from the Training of Trainers workshops to lead 9 additional workshops in El Salvador, Guatemala, Honduras, and Nicaragua. Again, participants rated pre- and post-workshop sterile processing knowledge on a scale from 1 to 10, and in TOT and trainee-led workshops, participants reported significantly increased knowledge post-workshop. Participants in non-TOT trainee-led workshops improved scores on post-tests of sterile processing theory as well. Moreover, non-TOT participants rated workshop utility highly, averaging 9.8 out of 10. Similarly to their TOT peers, the majority of non-TOT participants were very confident in their ability to teach the sterile processing material, but only 36% were confident in their ability to enact change. Free text responses as to why they lacked confidence were similar to the responses from the TOT participants, namely lack of administrative support and lack of resources. In conclusion, short Training of Trainers workshops and sterile processing can increase reported knowledge and scores and tests of sterile processing theory in both Ethiopia and Central America. Most Training of Trainers participants are very confident in their ability to teach sterile processing material post-workshops, but they are less likely to teach and less confident in their ability to enact change. Reasons reported include lack of resources and lack of administrative support. Moreover, TOT workshops are linked to improvements in sterility confirmation and instrument compliance in Ethiopian hospitals. Finally, trainee-led non-TOT workshops in Central America are as effective as TOT workshops in improving reported knowledge and scores on tests of sterile processing theory. In the future, we hope to evaluate and improve both the long-term efficacy and the local sustainability of these workshops. We hope to follow up with our colleagues in Ethiopia and Central America to assess whether knowledge from the workshop has persisted. We also hope to assess whether behavioral changes in sterile processing exist in Central America, as was seen in Ethiopia. Finally, we hope to discuss further with our colleagues the reasons for the reported lack of confidence and ability to make change. Future LifeBox workshops will seek to address and overcome these barriers. Thank you for your attention, and a particular thank you to my colleagues at LifeBox.